psychiatrist can, he can multitask. So he's going to take the questions, and then we're going to stop the recording and have more of an open and answer questions. Again, we're going to use the chat function. Looking forward to the session. So over to you, Cedra. Thank you.
Thank you very much, David. I am just going to set myself up in terms of the displays and so forth here.
That looks good.
Okay, so I mean, as David mentioned, I'm a consultant psychiatrist. I work at Berrywood Hospital. Currently, I work actually in the inpatient service, but I have, I think, about 11 years as a consultant in the community previously, and some of that time was spent working in primary care liaison. So hopefully, I'm a reasonable person to be talking to general practitioners. I've also got an interest in medical education. I'm in both undergraduate and postgraduate medical education, and I'm the Associate Director of Medical Education for the Trust and an honorary senior lecturer at the University of Leicester, in psychiatry. So I am going to try and sort of keep an eye on the chat in case there are questions that sort of arise as I'm talking, and I will hopefully notice those quite quickly if anybody does want to kind of clarify anything I'm saying or ask a related point. It might be that your question, is going to kind of be covered later in the talk, or if I think it's something that might be better to left till the end, I might look like I'm ignoring your question, but as I say, I'll do my best to keep an eye on that and clarify anything that seems pertinent. So what I'm mostly going to be doing is going over our local prescribing guidelines and just sort of talking through those, the reasons for them, some of the finer detail. We're going to talk a little bit about sort of how you introduce antidepressants, both in terms of the consultation itself and then in terms of schedules and when to monitor patients, or when to decide whether or not the treatment is effective. And then, as the last bullet point on the screen says, just when I think it's appropriate to refer to secondary services, really. So that all being said, the sort of quick word about when to use antidepressants. The main indication is for severe depression. When we're talking about a patient with severe depression, really antidepressants are the first line treatment. Psychological treatments, lifestyle, healthy lifestyle, and so forth. All of that is okay, but it is probably less effective. The more severe the depression is, the less effective psychosocial interventions are, and the more effective antidepressants and other biological interventions are. So as well as severe depression, you can use antidepressants in moderate depression, in obsessive compulsive disorder, in post-traumatic stress disorder, generalized anxiety disorder, panic disorder, and other anxiety disorders. The NICE guidelines for all of those conditions say the same thing, really, about where they fit into your treatment plan. They say that you should generally consider CBT or other evidence-based psychological treatments as about equal to antidepressants when it comes to moderate depression. In all of the other disorders, anxiety disorders and PTSD, you should consider cognitive behavioral therapy to be the first line treatment, and antidepressants should be considered either when CBT has failed or when the patient prefers to take antidepressants, or if there is severe functional impairment. Severe functional impairment is left to the clinician to define, but I would say, if the person is not at work, if the person isn't able to fulfill normal social obligations, family obligations, and so forth, then it might be more appropriate to consider antidepressants when we're talking about these anxiety disorders. So that's just sort of the indications, really. moving on to the actual guidelines, the simple version is in the center of the screen here. So our local prescribing guidelines suggest that the first line should be escitalopram or sertraline. Second line should be the other one, or mirtazapine. So if you've tried sertraline first, you would try either escitalopram or mirtazapine second. If you've tried, well, I'm not going to spell it out. The third line would be then venlafaxine, duloxetine, or vortioxetine. And that's the sort of simple 1, 2, 3 kind of version of the guidelines. Almost always going to be appropriate, essentially. And you're never going to sort of prescribe anything inappropriate, really, if you stick to that to those sort of simple bullet points. Within that, there is obviously nuance, and there are better choices and worse choices for particular patients, and so that is what I'm going to go into. One of the main things is that the younger you are, the more likely it is that fluoxetine is the most appropriate antidepressant for you. Below the age of 18, it's really the only antidepressant that has much of an evidence base at all. And our current sort of local guidelines say that in under 18s, antidepressants shouldn't be initiated in primary care. So that shouldn't really be a situation that arises. I know that in practice it does. So I think it's basically always fluoxetine in under 18s, and up to the age of 24, the evidence kind of shakes out to saying that fluoxetine is probably better than any of the alternatives. Mainly in terms of the risk-benefit ratio, it's not so much that it's more effective than other antidepressants; it's that it's less risky, is my evaluation of the evidence. So yes, so as I say, there is a bit of sort of nuance to that we'll come to. The first line being escitalopram or sertraline. These are SSRIs, selective serotonin reuptake inhibitors. The reason that they are the first line choice is because they're generally well tolerated. They're not at all toxic in overdose. When I say not at all, they're relatively not toxic in overdose compared to many other medications. And on large meta-analyses, they seem to have very slight advantages over other antidepressants in terms of efficacy. So they're slightly more likely to work than their competitors, is the sort of current evidence. For these medications and all antidepressants, it's important that we use effective doses. For escitalopram, that is 10 milligrams daily, and for sertraline, that's 50 milligrams once daily. Probably the main thing to be aware of is that escitalopram can prolong QTC, and so probably should not be given at the same time as any other medications that can prolong QTC. In the world of psychiatry, that means being careful about combining it with antipsychotics. Outside the world of psychiatry, what sort of thing I think it's most helpful to be aware of is that methadone can prolong QTC, and because methadone is often not prescribed through primary care, you might not get your kind of warnings on the electronic prescribing systems when you try to sort of add escitalopram into the mix. There are various other medicines that can prolong QTC, but as I say, I think methadone is one that you may be in danger of missing. So in psychiatry, I actually kind of tend to avoid escitalopram because we are so often ending up prescribing antipsychotics, but that's probably less of an issue in primary care, I suppose. So there is a question, and it says, I was advised in psych training that fluoxetine in the younger population should be avoided as high risk of suicide, especially in females. Has that changed? I mean, it's not an absolute. You're correct that the younger you are, the riskier it is to use antidepressants and the less benefit there is. So it's not a never kind of situation. And in fact, it's quite common for antidepressants to be prescribed in, well, your question just says the younger population, so I don't know how young you're talking about. But yes, as I say, below the age of 18, the guidelines say that these essentially should be initiated in secondary services, not in general practice, for exactly that reason, that they are, the younger you are, the more risk in terms of provoking suicidal ideation and therefore suicide itself. So really, people need quite close monitoring. The guidelines say that the young people who are started on SSRIs, fluoxetine, should be followed up within 1 week, which is, I think, difficult logistically. So I hope that answers the question. If not, do follow it up with a clarification. And is there evidence for the long-term efficacy of antidepressants? My understanding is the studies for which they were licensed ran for 8 weeks or so. Editorials in medical journals in recent years question their efficiency. I think we'll come to that at the end, if that's okay. I mean, it's a valid question, and that is reasonable, but I'm going to proceed with the presentation and then return to that at the end, I think. So that's the first line, escitalopram and sertraline. Mirtazapine is sort of joins the picture as one of the choices when we get to the second line. It is okay to use mirtazapine as the first line, I think, particularly if the patient has problems with sleep or appetite, reduced appetites, then it's possibly a better choice than either escitalopram or sertraline. But it's in the normal scheme of things, it would be a second choice. It's generally pretty well tolerated, but the main kind of caveats from the patient's point of view is that mirtazapine can cause weight gain, and it can be sedating. That can be beneficial for some people, but for some people it's too much. They will feel sedated the next day, and that may not be helpful. It may be overall a detriment to them. One of the sort of strange things about mirtazapine is that it can, at least theoretically, become less sedating the higher the dose you use, and that's because at low doses it is mostly an antihistaminergic drug, and at higher doses it begins to have its noradrenergic activity, which somewhat can somewhat counteract the sedating effects. So it can be that people will actually feel quite sort of zonked out really by 15 milligrams, which is not an effective antidepressant dose, and actually feel better from the point of view of that side effect at the 30 milligram dose. So I personally tend to start mirtazapine at 30 milligrams rather than at 15. That I don't think there's a lot of mileage in starting the 15 milligram dose. It's sometimes better tolerated at the higher dose, and that is the dose that's effective as well. So I think what happens in practice sometimes is that patients are started on 15 milligrams of mirtazapine and they find it too sedating, and then they will not agree to try a sort of higher dose, even though that side effect might be less at that dose. So I think you're better jumping in at the 30 milligram dose as a matter of course, personally, and that is my habit. Psychiatrists really like mirtazapine because it can be combined with SSRIs and SNRIs, and just in terms of the sort of practicality of changing people around between antidepressants, that's attractive, because you can sort of add it in and then change the SSRI while you're still taking mirtazapine. So it's sort of got a lot of, allows a lot of flexibility in its combinations and in the way that you can change people between treatments, and it's one of the strategies for it's one of the things that we do to try to treat treatment-resistant depression, more of which later. So that's the second line. And the third line is a sort of choice between venlafaxine, duloxetine, and vortioxetine. These are, I think, quite different drugs, or at least venlafaxine and duloxetine are quite different from vortioxetine. Both venlafaxine and duloxetine are serotonin and noradrenaline reuptake inhibitors. They have more side effects than SSRIs, and overall they're not more effective. So there's no sort of reason to jump in with these. I think it's attractive to think that because on the label it says that they affect more brain chemicals, it might be that they're more powerful, but there's no real reason to think that in terms of the data. They do cause more side effects, however, so that's why you wouldn't use them before the previously mentioned medicines. I think that the sort of attractive thing about venlafaxine is that there's a lot of flexibility in the dosing, and you can go up by several increments. There is a different neurotransmitter activity at higher doses. So whilst low doses of venlafaxine are essentially it acts as an SSRI at low doses, at medium doses it begins to affect noradrenaline, and then at very high doses it begins to affect dopamine reuptake. So there is at least a putative reason to think that higher doses might work where lower doses won't work. And generally speaking, that's not really the case with other antidepressants. So venlafaxine is perhaps the only example of a medicine where it might be worth trying higher doses if lower doses don't help the patient, or if lower doses don't make any difference to the patient. It's possible that higher doses of venlafaxine will. Duloxetine has less flexibility in the dosing. It's got less kind of stages that you can go through to reach its maximum dose, but it's particularly worth considering in a patient who has fibromyalgia, where there's a little bit of evidence that it can improve fibromyalgia symptoms, or chronic pain in general. It is actually licensed for diabetic neuropathy and also for stress incontinence. So I suppose if those are comorbidities, then it might be particularly attractive. And then vortioxetine, which is the newest antidepressant on the market in the UK, is a little bit like an SSRI as far as the neurochemistry of it's concerned, but it's generally probably got less side effects. Most patients seem to experience very little by way of adverse effects from vortioxetine. It does cause itching, which seems like a sort of idiosyncratic side effect. That's not particularly common in other antidepressants. And it also seems to have less by way of withdrawal problems than other antidepressants do. So those may be particular sort of those may be reasons to prescribe it in particular patients if they've had a terrible time with withdrawal from other antidepressants, for example, or just side effects in general from SSRIs or SNRIs. So those are the medicines that are on our local guidelines. It's not just messing up my presentation, sorry. Got back to the right screen now. It's not to say that other antidepressants are bad, it's just that these are, all other things being equal, these are probably the best, in a sort of algorithmic sense, these are probably the best ones to try unless you've got reasons not to. So some of the other kind of factors that you might consider in terms of choosing between these medicines or some of the other common antidepressants, sertraline is particularly considered to be one of the best choices in cardiac disease, so post-MI, for example, but it does tend to cause more gastrointestinal side effects than some of its competitors. So, if a patient's already suffering from irritable bowel disease or inflammatory bowel disease, then maybe sertraline is not the best choice. Sertraline is also a relatively good choice in pregnancy if antidepressants are needed in pregnancy, because very little of sertraline crosses the placental barrier. So that is sort of an attractive feature in that particular group of patients. Escitalopram and citalopram, I should say, are also sort of particularly recommended in people with epilepsy. But again, the sort of downside of escitalopram is that it can cause QTc prolongation, and we want to avoid that where that might be a particular problem for patients. Fluoxetine, I've already mentioned, that is sort of better for younger people. The other thing that I think a lot of people know this, but just to reiterate it, fluoxetine has a particularly long half-life, and so that does make it sort of maybe a better choice for somebody who is not altogether reliable about remembering to take their medicine. You are less likely to get withdrawal from fluoxetine because of its long half-life, and so again, for people who might have particular problems with that, that is probably going to work out better for them. And then paroxetine, which we sort of haven't mentioned before, is probably the only SSRI that is somewhat sedating, or at least many patients find it to be. So it is not unusual to take paroxetine at night time. It can assist with sleep, not in everybody. There will be people who have the typical kind of SSRI side effects of disturbed sleep, vivid dreams. Paroxetine can also cause that, but it is sometimes worth trying prescribing paroxetine at night. It can also cause weight gain much more than other SSRIs. And again, I expect most people do realise that it is probably the worst SSRI for withdrawal symptoms because of its short half-life. Returning to venlafaxine for a moment, the NICE guidelines for post-traumatic stress disorder specifically do recommend venlafaxine be considered relatively early in treatment, not as the first line, but perhaps we would jump to venlafaxine as the second line in PTSD rather than follow the rest of this depression algorithm that we're going through here. So those are just a few sort of extra nuances, I suppose, extra things to consider. There are other things that we kind of know about SSRIs. Something I didn't think to put on my slide that's occurring to me is that there is a little bit of evidence that fluoxetine is beneficial in diabetes as well, that it's got a positive effect on blood glucose regulation. So again, it might be worth considering that for a diabetic patient with diabetes, I should say. Just checking my questions, no further questions. I thought I'd say a little bit about augmentation strategies. Again, I really would expect these to be carried out under the guidance of secondary services, but again, realistically speaking, it's not always that easy to get patients into secondary services. And if you are wondering, sort of some of the things we commonly do, these are some of the things we commonly do. You will have seen these done in clinics, I'm sure, but and many of them are actually kind of pretty safe, really. So combining SSRIs or SNRIs with mirtazapine is very, very common. Patients who are taking this combination should have their blood pressure checked every few months, and they're more at risk of serotonin syndrome, so it's definitely worth warning about the symptoms of serotonin syndrome. Probably the second most common thing is combining an antidepressant with an antipsychotic, and that's usually quetiapine or aripiprazole. Aripiprazole has a sort of has a better side effect profile than other antipsychotics, and also being a sort of partial dopamine agonist has a sort of more plausible rationale for its use as an antidepressant, I suppose, than other antipsychotics. Quetiapine is the other one that's commonly used, and that I think is based on its evidence base as an antidepressant in bipolar disorder. So again, it's got a kind of a little bit of a reputation, if you like, for being antidepressant, but of course, when you're taking antipsychotics, you need to have the physical health monitoring that goes along with those. So that is not to be ignored. combining antidepressants with lithium has a long and well-evidenced tradition. And I think a lot of people where their patients are stable, who don't have suicidal ideation, where people are able to be reliable about keeping up with the blood tests, keeping up with the actual dosing, then that might be a very good option for people. An antidepressant plus buspirone. I think buspirone is kind of one of these medicines that you either know about it or you don't, but it is a serotonergic drug that is used in the treatment of anxiety disorders. Has to be taken regularly and long term to be effective. The BNF licensing says that you shouldn't use it long term for some reason, so its utility is kind of quite stymied really by its licensing. But combining antidepressants and buspirone in as an augmentation strategy is a thing that's worth doing. The augmentation strategies that have the best evidence base are the last ones I've put on the list here, because they're both quite difficult to actually enact in practice, in my experience. And that is combining SSRIs and bupropion, which is the chemical name of Zyban, that you'll be familiar with as a smoking cessation drug. It is actually an antidepressant and is licensed as an antidepressant in many countries. A combination of an SSRI and bupropion is more effective than many of the things I've just mentioned. And also combining antidepressants with T3 with thyroid hormone is also got probably a better evidence base than the other things I've just mentioned, but for various reasons these things are quite difficult to actually do in reality. So you see the first four I've mentioned there a lot more commonly. I think I sort of skipped a line that when I started talking about augmentation strategies. The role of augmentation strategies is at the point where a patient is benefiting somewhat from an antidepressant, where you've reached either the limit of the safe dosing or the limit of the patient's tolerability of that medicine. You know that it's helping them, and you sort of want to amplify the effect further. So that is when you use augmentation strategies. It isn't a sort of thing that you just sort of try in a new patient, or when you've run out of other options. It's meant to be enhancing a partially effective treatment. So that's when we do that. Or at least in theory, that's when we should be doing that. So that is augmentation strategy. So related, I think it's probably worth saying something about treatment resistance. And first thing to say about treatment resistant depression is that some people say we shouldn't call it treatment resistant depression. So that's been the traditional terminology. There's a sort of growing movement to call it difficult to treat depression rather than treatment resistant. And I think that's for reasons of it kind of promoting a sort of sense of futility in the patients who the label is being applied to. If they feel that you're saying that their illness is resistant, then that might promote pessimism and a sort of sense that nothing can be done, whereas the reality is lots of things can be done, and eventually it is possible to treat a lot of these people. It's just a matter of trying different treatments systematically. So academically, this term difficult to treat depression is defined as having either no response or very little response to antidepressants when these medications have been tried properly. When I kind of come across these kind of patients in practice, I think a couple of things that it's worth just wondering about when we're sort of thinking this person doesn't seem to be getting from their depression. It's worth revisiting the diagnosis. Do they actually have depression? Do they actually have, the sort of more severe side of depression? Do they have the physical symptomatology of depression, which antidepressants seem to be better at dealing with? Are there comorbidities that we've missed? Could this person actually have bipolar disorder, for example? Those are sort of kind of going back to basics kind of questions that I think it's worth just sort of pausing and reassuring ourselves that we're actually pursuing the right kind of treatment paradigm. And the other thing that I think it's easy to sort of assume is happening is that the patient's actually taking their medication, because it is noticeable through I've had quite a lot of exposure to this now. It's quite noticeable that a lot of patients will be absolutely certain that they are taking their medicine reliably. And one of the sort of good things about the electronic prescribing systems and System 1 is that you can see quite clearly how often prescriptions are issued. I very frequently would come across patients that have only picked up, for example, 9 months worth of medication in the space of 12 months, which tells me that that's at a level where that they cannot be taking their medicine reliably. So that's worth looking at, and it doesn't take very long to check that. If your practice uses System 1, I don't know how that might be on EMIS, but it's really worth looking at that prescriptions screen and just sort of checking that the patient's not sort of kidding themselves that they're actually taking this medicine as prescribed. So all of that being said, it is relatively common. It's probably about 30% of people with depression who fall into this category. So that's a very significant number of people on a population level. This will vary from area to area, but what we can do about people with treatment-resistant depression in Northamptonshire is we can put them forward for repetitive transcranial magnetic stimulation, RTMS. It is only available through the CMHT, so they would have to be referred to secondary services to receive that. Equally, the other treatments I've mentioned here on the screen, ECT and ketamine treatments, are also only available via CMHTs. So that de facto is a point at which you can consider referring people into CMHTs if they sort of qualify for these treatments by not responding or only having minimal response to 2 antidepressants. So that is that screen. I just see there's another question here. You talk with great ease about augmenting with antipsychotics, which will come as worry to GPs who have to attempt to monitor these patients. How long should secondary care monitor these patients before handing back to GPs? Yes, I mean, I think it's difficult in secondary services as well. We're not actually great about monitoring antipsychotics, even in the CMHTs or even in the hospital, for a variety of reasons, I think. Some of which are sort of patient side and some of which are systemic issues that we just have within our organizations. So I could interpret the question 2 ways. How long do I think secondary services should monitor these patients, or how long realistically could secondary services monitor these patients? So I think the kind of current setup is that we would do monitoring for about 6 months after starting the treatment, and after that point it should be annual checks, unless the patient sort of becomes symptomatic with some of the potential problems that we're talking about. That's sort of that sort of makes sense, I think, in the current within the current frameworks. I think the implication of the question is, shouldn't it be quite a long time? I sympathise with that point of view. I think in an ideal world it would be quite a long time, and if we had the capacity to do that, I'm sure we would do it for longer. So I don't know what else to say about that. It's really a sort of capacity issue, and I appreciate that the capacity of primary care is extremely limited as well. These are the kind of questions for commissioners and so on. But as I say, I think it makes sense for it to be about 6 months at a minimum. So that is everything I'm going to say about the actual kind of choice of medication. What to say to patients when they're being prescribed. I think it's therapeutic optimism is important. It's important to say that most people do recover from depression. It's important to make sure that patients realise that taking antidepressants regularly is needed for them to have their benefit. I think it's best to say to patients that the benefits emerge at around about 3 to 4 weeks. There is some sort of reason to think that the actual benefits occur quicker than that, despite what we've traditionally said. But in a sort of I guess in practical terms, when many patients will have lives that are full of stresses and variables and ups and downs in terms of psychosocial stressors, I think it's better to be a little bit more circumspect and to say roughly 3 to 4 weeks. I wouldn't say longer than that. I think we've traditionally said 5 or 6 weeks sometimes, and that probably is just hanging around too long to sort of wait and see. Even 3 to 4 weeks is actually sort of pushing it a bit. That they probably should be benefiting from antidepressants a bit before that. The problem is side effects might occur immediately, and I think it's best to just say that to patients, that you might get the bad side effects before you get any of the benefits. Please do persevere with it. It's really throwing the baby out with the bathwater if we don't stick it out and try to see whether things get better the more that you stay on a medicine, because many of the side effects are transient. The kind of question of how do antidepressants work is a kind of hot topic, I suppose. There's been various things in the media about the sort of phrase chemical imbalance, and I think it's pretty clear we shouldn't say to patients that antidepressants correct chemical imbalances. There's definitely, a lot of that out there, and I have met a lot of patients who are quite invested in the idea that they have a chemical imbalance. You sort of can't really tell them otherwise because they believe it so strongly. But I think at least in new patients, it's not the right way to explain what antidepressants are doing. They do affect brain chemistry, neurotransmission. They do affect serotonergic and noradrenergic systems, but it isn't because there's something wrong with those systems in the first place, or at least we don't have any evidence to suggest that. I think that is kind of how to talk to new patients about that. What patients who already think this, what are we going to say to them is a different question. But I mean, in all things, I advocate just transparency. If we've changed our mind about how things work, then that's what we should say. If we've explained things in a simplistic fashion and it's not really accurate to the best understanding of an intervention, then we should say we've explained it in a way that's too simplistic. It's, I think, for almost all patients, kind of important and powerful to validate their own perception of their reasons for being depressed. We often don't know any better than the patient themselves why they're feeling the way that they're feeling, and I think it's very much worth just taking a moment to say, it's your feelings are legitimate, and the pressure that you're under is enough of a reason to feel the way that you feel. You don't need to sort of think don't need to sort of think in any more complex terms than that a lot of the time. And I think, again, probably preaching to the choir, but just, not neglecting the kind of healthy lifestyle advice in terms of diet, exercise, keeping meaningful activity as part of your routine, reducing smoking and alcohol consumption, sleep hygiene, self-care. There's studies that show that expressing gratitude or being grateful is associated with less depression. So in the right patients, I will often talk about that. Smoking cessation is particularly important. there are some studies that show that smoking cessation can be as effective as antidepressants in moderate depression. So many patients kind of, and I think many doctors and psychiatrists kind of buy into this narrative that, well, you know, smoking, it's the only thing I've got. It's the only thing that kind of makes me feel happy, or I've got nothing else going for me. At least I get a little bit of joy out of smoking. Smoking can maintain depression through its sort of infliction of withdrawal effects. So actually stopping smoking, smoking is probably giving you depression rather than a little bit of joy. And for various reasons, mood diaries, I think, are a good idea. That's partly for our own reasons. It's kind of good to have some measure of progress, some measure that's patient sort of centric. Patients are sort of judging themselves by their own criteria, if you like, that they're defining their own recovery, and you know, can see their own change over time, hopefully for the better. But even if it's for the worse, that's useful information, and it's particularly good and useful for us if we're making changes to treatment, if we're starting something new, whether it's CBT or an antidepressant, then the patient's own kind of record of their progress will tell us whether it's working or not, or whether it's helping them in the way that they think is important. So I often advocate that, particularly in other mood disorders, but I think it can be useful in depression as well. And there are various free apps that people can just download to kind of make records of their moods on a day-by-day basis. So that I think is quite a good an easy thing for patients to do. Okay, so a bit about starting and stopping. So as I said, I think it's best to say to patients that antidepressants kind of take 3 or 4 weeks to start working, but actually the evidence is they work a bit quicker than that. The 3 to 4 sort of week or 5 or 6 week is based on sort of studies where you sort of see antidepressants separating from placebo at about that time frame. But that's not when, from the patient's point of view, if they're going to work, the patient should notice it before you know, sort of the 4 or 5 week mark. So that's more of a sort of experimental thing that they take longer. They take longer to separate from placebo, but that doesn't matter to your patient who's taking them in outpatients. It is important to warn particularly anxious patients that that it's common to have a transient increase in anxiety when you first start taking SSRIs, especially, and that SSRIs can provoke suicidal ideation. It's rare, but obviously serious, and it's good to give people emergency helplines and make sure they know what to do if that does happen. When should you kind of decide that an antidepressant isn't helping? So if there's no improvement at all at this point, 3 or 4 weeks, then it is probably right to just change treatment. It's especially if you're talking about a sort of patient who's relatively early in the treatment algorithm. If they're not noticing any difference at all, then it probably isn't worth raising the dose and sort of seeing if that then helps. It's probably better to just try the next step on the protocol to try the next medication. The chances of them suddenly starting to respond at that point are low enough that it's worth just trying something different at that point. If you are switching between antidepressants, then there are different guidelines around. I think most people are in the habit of cross-titrating by reducing the dose of the initial drug and introducing the small dose of the second. For almost all the medicines we're talking about here, it is probably okay to just straight switch between them. The withdrawal symptoms from one should be alleviated by the new medication, and that is supported in expert guidelines. But I must admit, I still don't really do that. I do the gradual cross titration. So as I say, either way is okay, but I think you have to kind of get yourself confident with whatever you're used to. You'll find it difficult to suddenly stop doing that and try the other way. The one to be careful about there, though, is fluoxetine. You shouldn't combine, if the initial drug is fluoxetine and you're switching to something else, then you shouldn't sort of cross titrate fluoxetine. Really, it should be stopped, and you should actually wait a week or so before starting the new medicine. At least in most cases. When you're stopping antidepressants, you should withdraw slowly, really, and I think basically as slowly as possible might be the way to say it, but it should take place over at least 1 month. That would be the minimum. Most patients, that's going to be okay, but there are some patients who will need extremely slow withdrawal schedules, and the sort of most recent advice in those patients that are having a great deal of difficulty is that the reduction in dose is best done in a hyperbolic mathematical pattern. So that what that means is you decrease by a set percentage rather than by a set degree. So you might reduce the dose by 10% per month or something like that, rather than reduce by 50 milligrams and then 50 milligrams and then 50 milligrams. If you reduce by 10%, you're actually reducing it by less and less each time you make a dose change. The number of milligrams will be less, and that should give a kind of smoother experience. This is to do with the way that receptor occupancy works, and if you sort of imagine going from the difference in receptor occupancy going from 200 to 150 of sertraline is minimal compared to the difference between 50 milligrams and 0. That's a huge change, whereas actually these sort of changes at the high end of the dosing schedule are almost nothing when it comes to what's actually going on a cellular level. So the question about cross tapering, do I have a reference for guidelines we can use to cross taper? I don't have easily accessible reference for you there. The place that there you go, somebody's answered. So see in the chat for the easily accessible guidelines. I was going to say I use the mostly prescribing guidelines, but those are rather expensive to keep up to date with, and I wouldn't expect a non-specialist to want to do that, really. But our kind facilitator is sharing a whole bunch of links for an answer to that question. So thank you for that. Right, so nearly done. The last slide I have, or the last screen I have, is just on when to refer. So I think hopefully this is obvious, and hopefully these are criteria that are actually honoured by our service. If somebody is acutely risky, then they obviously need to be referred to our crisis team. I think it's reasonable to refer to the community mental health teams in the face of medical complexity, whether that is about renal failure, liver problems, cardiac comorbidities, just somebody with lots of problems and they're on, lots and lots of different medications and interactions become challenging. I mentioned the sort of criteria for treatment-resistant depression. I think in practice, if you try to refer somebody who hasn't attempted CBT and who isn't risky, you're probably going to get the response that they should try CBT before coming to the community mental health team. But if they have done that, or if for some reason CBT just isn't suitable for them, they don't want to do it, then non-response to 2 or 3 antidepressants, I think, is reasonable to make referrals at that point. And also, I mentioned this kind of question of reassessing the diagnosis. If you think that there are sort of other, perhaps more serious or perhaps just complicating psychiatric comorbidities, then I think it's reasonable to refer to tease that out to get that assessed. Okay, so that concludes my presentation. I will return to the question that I skipped from the chat. Let me just scroll back up to get it again. So the question was, is there evidence for the long-term efficacy of antidepressants? My understanding is that the studies for which they were licensed only ran for 8 weeks or so. It's true that the evidence is not as robust as you would like. I think the evidence is reasonable, and there are some longer term studies. It's not that the only studies there are drug company kind of cherry picked, if you like. But I think, as with anything, there's a degree of publication bias. There's been a degree of pragmatism in terms of study design and I guess the practicalities of conducting research. So I mean, I think I kind of acknowledge the concern about that, but I don't think there's really serious doubt that antidepressants only work for 8 weeks and then, and then we should try something else, or that's where the cutoff is. I do think that there's a need for sort of better quality longer term studies, but I can't sort of I can't really sort of flesh out my thoughts in a very detailed way in this format. But yeah, I mean, I think we should always be a bit kind of circumspect, I suppose, about the quality of evidence that we've got, even for things that have been around as long as antidepressants. It's not what I would think of as gold standard evidence. And then another question has just been asked, actually. Sorry, I missed at the start. Is citalopram ever recommended now? Right. No, I don't recommend citalopram now. Citalopram is better, so I don't, and it's not appreciably more expensive anymore. So for many years we were sort of disincentivized from prescribing escitalopram. It was whatever, Amber 2 or something like that, and that's no longer the case. So there's no advantage of citalopram over escitalopram. The only time I would think that would be good to do is just the patient is asking you to, and possibly they've got some previous experience with citalopram and just have slightly, they've got a sort of an attachment to it based on experience. Do I have any more specific tips for depression in the elderly with or without dementia? I mean, there aren't any. I mean, I guess it's not my specialty. The thing that I think that immediately springs to mind is to be careful about sodium levels when you're prescribing SSRIs to older people. They can SSRIs can cause SIADH, and it does seem to happen, at least enough for me to be saying something about it. I've seen it a fair few times. So I think that makes sense to just be, kind of have your eyes open, particularly if the person seems to be getting more confused after starting antidepressants. I mean, I think other than that, they're still the best choice. SSRIs are still the best choice for older people. For some reason, there is a sort of leaning towards using lefepramine in older people. I don't really know what that's based on. It just seems to have been a kind of tradition in older people's psychiatry for as long as I've been practicing. I don't think it's actually evidence-based. Lefepramine is I think it's a reasonable antidepressant. I have heard some sort of fairly well-respected pharmacists cast doubt on the evidence base of lefepramine, but I haven't looked into it myself. So I feel a bit like just a bit wary about saying it's okay, but it's certainly well tolerated compared to other tricyclic antidepressants, and I think it seems to be roughly as good as anything in my experience. Shall I stop sharing my screen? I'm thinking.
Thank you for that. I mean, that's a tour de force of kind of going through, and we will share the county guidelines, which Joe kindly slipped in those couple of links. And so there's quite a lot in the county guidelines of other things and other points that people can do. But you've taken us through with detail. It'd be lovely to with other questions. I think you've just got a bit of time left, so we will share those. And I think you've covered this aspect of chronic, what sometimes in NICE guidance, they don't call treatment-resistant depression, call it chronic, but you have to have it in NICE guidance for 2 years before it can be called chronic. So thank you for clarifying that point, which is very well made, that 2 treatments and CBT, then really think, have we used third line treatment? Because I've seen a lot of times when people haven't had the third line and people get switched back to an SSRI, and the guidance is to switch to a different class, isn't it? Rather than switching back, because I know that a lot of times people get switched back, and that seems to be from the evidence of what we're doing locally sometimes.
Yeah, I mean, it actually occurs to me to say one other thing about chronic depression. I guess maybe just another sort of synonym for the same thing, really, which is that you do sort of get, psychiatrists get caught up in this. I think patients do as well. The sort of quest for perfection, and you can sometimes sort of cast away effective treatments, or at least more effective treatments, in the quest for sort of a perfection that may not be achievable. So occasionally it's a very difficult conversation to have, but I will sometimes say to patients, look, actually the chances are you've actually been on the best treatment already. We could probably indefinitely try increasingly unlikely and sort of strange and less evidence-based treatments in the hope that one of these is going to work for you. But it might actually be true that one of the first antidepressants that you took was somewhat effective and is actually the best you're going to get out of antidepressants. So I mean, that's very difficult to hear, and that's a particular stage in somebody's journey, if you like, that I think it's sensible to have a conversation like that. But perhaps that's something a psychiatrist should be saying rather than a GP. But it is, kind of objectively true that the best treatment isn't necessarily one that you're about to have. It might be one of the ones that you've had, and that might be as good as it gets. So it's a tough conversation to have, I think, and you have to be quite brave to raise it and have a good working relationship with the patient, really.
Well, Cedric, anything, Mike, you want to add? Because I just, from your point of view, oh, you're on mute, Mike. Mike, I can't hear you again. So your mic isn't. No, we're sorry, we can't hear you. So your words of wisdom you'll have to put into the chat. But I think we've come up to time, come against time. So we appreciate people have had a busy time. We can stay a bit for those that wish to, but we recognise the life of GP is, as our Royal College of Chairs said, it is actually carries a health warning in itself at the moment. So we wish you all well. Anything we can do to help with these webinars, we're very keen for topics, so do pop them into the chat. Any topics that you think, you've got the list that we're going to cover, but if there's other topics there, and underlying causes is the elephant in the room. That I don't know whether that's the underlying causes of depression, etc. Is that how you'd read that question?
Yeah, I mean, I think they are often socioeconomic. if that's a quick and maybe glib answer, but we see depression much more in people who don't have much going on for them socioeconomically.
Certainly, the evidence is from the Prevention Concordat is the best thing the government could do would be to give people a living wage, and that is the best evidence-based intervention, and that was looked at internationally. So I can quote that from the Prevention Concordat. So yes, socioeconomic and also abuse and trauma, and often there's unrecognized trauma that has happened. That and I think that's certainly, Mike, you as a therapist of.
Yeah, I think that's huge. And so many people, when you explore, they do have and have had stuff going on in their life that they just haven't been able to get over. Yeah.
And I think the other point is the existential issues. Yes, I would agree that we need also to recognize people's purpose, meaning, gives people, those that have a reason for why, can survive almost anyhow, to quote Viktor Frankl. But yeah, so I think an unemployment does matter, indeed. Thank you for these comments. I think
it was a really good, really interesting, good presentation. Yeah. Fantastic. Thank you.
Thank you so much.
Appreciate your time, everybody. Thank you. You've got other things you could be doing in the evening, so.
Thank you all. I don't see any other questions, so I think we're going to call it a wrap now. But obviously, do be in touch, and if there's any topics, again, just to mention that you don't see there, then we do our best to let you know. I'm checking whether we can actually do the Wellbeing Launchpad next time, which is the information sheet. If we don't have that up front, we will just slightly alter the order of the content and put it back a bit later. The Wellbeing Launchpad gives all the data for Northampton. Hope it'll be around the county, of all the local services, those what I call a stitch and bitch groups, which can be very helpful for people just to be engaged with, or knit and natter if you don't want stitch and bitch. Anyway, I think that's enough. All the best to you all. Keep well, keep safe, and thank you for all that you're doing in primary care at the moment, and in any care that you're doing at the moment. It matters. Thank you.
Yeah. Bye-bye.